Okay, we're going to go back to talk about pharmacological management. Again, there's a great chart, 18-9. You are not responsible for that chart. What you are responsible for is that the rheumatologist usually makes the decision about appropriate drug therapy for patients with rheumatoid disease based on the severity of the disease. Initially, most patients are managed with a disease-modifying anti-rheumatic drug. The first line modifying anti-rheumatic drug is methotrexate, and it is an immunosuppressive medication, and it's given in a low dose, usually once a week, and it is the mainstay therapy for rheumatoid arthritis because it is effective and relatively inexpensive. It is slow acting, taking 4 to 6 weeks to begin to control joint inflammation. Okay? You also need to monitor these patients for potential adverse reactions. So please make sure that you look at the drug alert talking about methotrexate, which is MTX, on page 322, and that is the Nursing Safety Priority Alert drug alert, okay, on page 322, and it's about patients taking methotrexate and their risk for infections due to the decreased immunity. Other non-pharmacological treatments with the goal of pain and inflammation reduction and preservation of joint function, and balance and rest. A lot of times they use isometric exercises. They'll use low-impact aerobic exercises. A lot of times they will do swimming or walking or even water walking, where they just walk across a low pool. They will use splints or assistive devices. Make sure that they have a well-balanced diet with omega-3s. And sometimes the patients will require surgery for joint replacement. Just so that you can look at the different isometric exercises to maintain joint function without stressing the joint, look on page 303, chart 18-5 gives an examples of those. You are not responsible for knowing the exact exercises. You are responsible to know that in order to increase mobility and to maintain joint function, these patients need to have low impact aerobic exercises and do isometric exercises. We're now going to talk about lupus erythemus. There are 2 classifications of lupus. There is SLE, which is the systemic lupus, and that's the one that we're going to spend the majority of our time talking about today. But I do want you to know that there is a small percentage of patients with lupus who only have the DLE, which is the discoid lupus erythemus, which only affects the skin. Okay? Just know that there is a small percentage of people who only have the lupus that affects the skin. The majority of patients with lupus have the systemic lupus. DLE affects only the skin. It is not systemic. They will have a butterfly-shaped rash. It's usually dry and scaly, a raised rash across the cheeks and nose. It also can appear like sun-exposed skin, like they have a mild sunburn. It will have periods of remission and exacerbations. The discoid is like a coin-like lesions that can cause scarring. These patients can have problems with alopecia. Laboratory testing is skin biopsies to determine if it is DLE. Medications are topical steroids. They sometimes will use ultraviolet light. They also will use Plaquenil. Education is to have the patients chart their skin and hair. And there is community resources. On page 327, the major skin manifestation of both DLE and SLE is the dry, scaly, raised rash on the face. And this is a picture of it on page 327. Just keep in mind, with the DLE, that is really the only thing they have is the skin. It only affects the skin. It is not systemic. There is psychosocial results of lupus can be devastating. You have to teach patients about having frequent eye exams. before starting new therapies and about 6 months afterwards. Make sure that you look at the action alert on page 328, where it talks about teaching the patients to protect their skin from exacerbations. Okay, it talks about here when patients have instruct the patients to avoid prolonged exposure to sunlight and other forms of UV light, including certain fluorescent lights, reminding them to wear long sleeves, even though sometimes, because you want to be able to decrease that ultraviolet light exposure by the sun. Okay, so the only main thing I want you to know about DLE is that it is not systemic, that it affects only the skin, and both DLE and SLE have the butterfly-shaped rash. So with DLE, the only real thing you need to know is that it only affects the skin. Moving on to systemic lupus. Systemic lupus is a chronic, progressive, inflammatory connective tissue disease. It is an autoimmune disease with remissions and exacerbations. Lupus nephritis, which is in the kidneys, is the leading cause of death from SLE. They can also have the butterfly-shaped lesions. They can also have the coin-like lesions and alopecia. They can have polyarthritis, which is similar to RA, but they do not have the RA factor. Generally, if they have a fever, that is a classic sign that they're getting ready to have a flare-up, and so that's something to keep into mind. They will have systemic organ changes as well. Systemic lupus can cause major body organs and systems to fail, especially the kidneys. It affects women 10 times more than men. The onset occurs most often during the childbearing years, between 20 and 40. Lupus is probably caused by a complex combination of genetic and environmental factors. The true cause is still unknown. Polyarthritis is most common in small joints and knees. The fever is the classic sign that an exacerbation is coming. They have various degrees of generalized weakness and fatigue, anorexia, and weight changes. Weight loss can occur. You want to assess the family and the patient's feelings about the illness to identify areas requiring intervention. You also want to talk to these patients about skin protection that is mentioned on chart 18-12 on page 328. Chart 18-11 on page 326 discusses the key features of systemic lupus. It can affect the kidneys, resulting in proteinuria, hematuria, fluid retention, and changes in urine output. They can have respiratory issues, including pneumonia and pleural effusion. Neurological changes can be seizures to migraines, abdominal pain. They can have splenomegaly or inflammation of the spleen. Cardiovascular wise, they can have pericarditis and Raynaud's phenomena, where you get the little the coldness in the extremities. So just keep all of those in mind as part of your assessment findings with someone who has systematic lupus. Remember that skin involvement, the major skin manifestation of both DLE and SLE, is the dry, scaly, raised rash on the face, or the butterfly rash. They will still have those coin-like lesions. They can have skin changes and polyarthritis. They can have bone necrosis from lack of oxygen. They will have from chronic steroid therapy that may cause constriction of small blood vessels supplying joints, which can cause tissues to die. The hip is the most commonly affected joint, and they will report pain and decreased mobility, and sometimes these patients will require total hip surgery. Because SLE is an inflammatory condition, fever and fatigue are common. Remember that fever is the classic sign that an exacerbation is going to occur. A lot of times these patients do have chronic fatigue and generalized weakness, and this can affect their psychosocial environment. They can become depressed. They can have anxiety. And unfortunately, there's a lot of myths about lupus, and so people will feel very embarrassed of their disease. So you want to make sure that you're doing some good therapy as far as making sure that we have listened to what the patient's concerns are about their chronic fatigue and this illness of systemic lupus. Remind the patients to make sure they're having frequent eye exams while taking Plaquenil and other immunosuppressants. With patient education, make sure that you look at chart 18-12 on page 328. It discusses the patient with lupus, making sure that they're cleaning their skin with a mild soap. Dry your skin thoroughly by patting. Don't rub your skin. Apply lotion, especially to dry areas. You should not use powder. Only use cosmetics that are that are moisturizing. You shouldn't use anything that's drying. You should avoid direct sunlight and any type of ultraviolet rays, including tanning beds. Should always wear sun-blocking agents and make sure that you're wearing an SPF of at least 30. These patients should also be seen by a dermatologist once a year to have their skin assessed.